Well, hello everybody, and welcome to the Adult Obesity Guideline webinar series hosted by the Office of Lifelong Learning and Obesity Canada. Uh, we acknowledge that we are on the traditional territories across Canada, First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Uh, my name is Arya Sharma. I'm professor of medicine here at the University of Alberta, and I'd like to start off with a few housekeeping comments. If you have questions pertaining to technical difficulties or the L3, which is the Lifelong Learning Program, or any of the Obesity Canada programs, please use the chat feature of the webinar while you're on here. If you have questions to the panelists or to the speaker, please use the Q&A feature of the webinar. We will try to answer, several questions following the oral presentation, and we'll try to respond to some of them perhaps through the text window. But at any point, you can use the Q&A button at the bottom of your screen to submit a question. We anticipate that quite a few questions. Please look at the questions that have already been asked, and you can actually vote the questions that you would like answered up, and we'll try to get to them. Obviously, because of time limitations, we can't guarantee that all panelists will be able to respond to all of your questions. Now, having said that, just a quick introduction to myself again. I'm professor of medicine here at the University of Alberta. I work in the field of obesity medicine. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. As many of you probably know, the Canadian Clinical Practice Guidelines are very expansive. There's 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and a lot more. And they're all written by Canada's top researchers, health practitioners, and experts. There were also a lot of patients involved in the creation of these guidelines, which really makes them the truly patient-centered clinical practice guidelines on obesity. And it took more than 2 years to produce them. So I'm very pleased today that we have Dr. Stephen Glazer who will be joining us, and he'll be presenting on bariatric surgery. Dr. Stephen Glazer holds certification in internal medicine and intensive care medicine from the University of Toronto, and is both a provincial and a national leader in bariatric medicine. In 2010, Dr. Glazer became the medical director for both the bariatric and surgical and medical programs at Humber River Hospital, which is a dedicated center of excellence for the management of obesity in Ontario. He's an active board member of the Ontario Bariatric Network, sitting on numerous subcommittees, including being the vice chair of the OBN Medical Program Task Force. He is involved in establishing the standards of care for patients in Ontario, participating both in surgical and medical approaches for obesity management. In 2012, he became a diplomat of the American Board of Obesity Medicine, and in 2019, he became the president of the Canadian Association of Bariatric Physicians and Surgeons, CAPS, which was a partner together with Obesity Canada in creating these guidelines. So, Stephen, welcome to this webinar, and you might want to share your screen now and get us started.
Okay, thank you so much for that warm introduction. And as you acknowledged, I just wanted to extend my gratitude to both Obesity Canada and CABS for their collaborative work on these guidelines. I also want to recognize the authors of the sections from which I'm going to talk about today, Dr. Bariatric, Dr. Gagne, Dr. Hong, and Dr. Shao, all of whom contributed to the guidelines. And I'd also like to acknowledge and express my gratitude to Dr. Sharma, who has, for many of us, been an exceptional mentor and has really put obesity exactly where it should be right now, a chronic disease getting the attention that it really deserves. So thank you, Dr. Sharma. So let's start. We have a long agenda for today. We're going to talk about bariatric surgery, pre-op, post-op, and intra-op. I hope you enjoy it, and I welcome your questions thereafter. So starting off, we really do need to acknowledge the fact that really obesity is a chronic relapsing disease, and it deserves that attention. It's secondary to excessive adipose tissue that impair function and health of an individual. And that has a significant impact on individuals' lifespan. And we know that for many individuals with living with obesity, health behavior interventions just don't cut it. They don't seem to be as effective for long-term weight loss maintenance and for durable metabolic recovery. And as a result, bariatric surgery is an effective option that can be exercised by a patient that may be more effective than standard medical approaches, especially improving things like diabetes and other comorbidities, which we'll talk about in a few minutes. So first of all, let's talk about the selection and the preoperative workup of these individuals undergoing bariatric surgery. How do we know who's going to be successful in losing weight in the postoperative period? Well, that's quite challenging. So when we look at behavioral changes, we know that exercise of moderate degree after bariatric surgery is associated with additional weight loss. But also we do know that implementing health behavior changes before surgery may be helpful. However, overall, when we look at the success of weight loss at approximately 2 years and beyond, there really isn't any significant added benefit for behavioral intervention. We do know that a patient's eating patterns are addressed in preparation for bariatric surgery. They play a big role in the postoperative success or failure. We also do know that individuals have experienced significant past trauma, and that also impacts on the success postoperatively. When we look at things like binge eating, where maybe up to 20% of patients that have binge eating disorder have had a history of sexual abuse, that also is a significant contributor to stress to a patient. But we really don't have good data of whether or not that will predict a successful weight loss postoperatively. We also know that preoperative, the psychosocial characteristics of patients and the eating behaviors do play a role in helping patients do well postoperatively. And that's why we spend a significant amount of time addressing many of these issues in preparation. That's why bariatric surgery is not a short lead time preparation. We need to train the patients so that they're successful. We also know that the preoperative weight management attempts may reflect the ability of a patient to follow the plan and even an exercise plan postoperatively. In addition, preoperative weight loss may decrease the difficulty in terms of actually the surgery. What is it? What have we found? We found that it may minimize the amount of blood loss. It may, in the short term, improve weight loss and short-term complications. But overall, it doesn't really affect any excessive weight loss when we look longer term, aside from the fact that the surgeons perceive that the surgery was easier in individuals that have lost weight preoperatively. So as a result, we try to encourage patients to have a preoperative weight loss more by changing their eating behaviors, etc. But it's not mandatory and not a prerequisite to move forward with bariatric surgery. But equally as important, what about the nutritional status of patients, and how do we prepare patients for surgery? Well, all patients that are undergoing bariatric surgery are given a very low-calorie meal supplement prior to surgery. Some 2 weeks, some 3 weeks, it depends, some even longer. Why do we do that? Well, we know that the administration of these very low-calorie meal supplements may help reduce the size of the liver by a significant amount and also may decrease your visceral adipose tissue. And so we enforce that practice prior to surgery. But that too really has not had a significant impact in weight loss postoperatively. What about other risk assessments prior to bariatric surgery? Well, as I alluded to earlier, nutritional status is very important to address before. We do know that people living with obesity in and of itself, not necessarily bariatric surgery patients, but patients living with obesity have a higher risk for inadequate nutritional status. They higher risk for malnutrition and micronutrient deficiencies. And studies have shown that a large proportion of patients actually that are undergoing bariatric surgery are malnourished. And as a result of that, they may have an increased risk of complications postoperatively. And we do know that the patients that have higher BMIs may be at increased risk for malnutrition. Not only that, their postoperative care can be complicated by nausea and vomiting if they were malnourished preoperatively. So as a result, in the workup of patients undergoing bariatric surgery, we do extensive blood work looking for micronutrient deficiencies, anemias, metabolic abnormalities, and we try to optimize those prior to surgery. So many patients are started on a regimen even before they have bariatric surgery. And we also know that when we look at other vitamin deficiencies, patients that may be on proton pump inhibitors or metformin, they may have a higher incidence of B12 deficiency. What about smoking and nicotine use? Well, this is actually very challenging for us. We do know that nicotine is associated with postoperative ulcers. It increases bile salt reflux. It increases the risk for H. pylori, which in and of itself may potentiate ulcers. Smoking may affect prostaglandin synthesis, which we know is part of the barrier that the stomach creates to against acid. There are effects on the actual mucus of the stomach, and most importantly, mucosal blood flow. And why is that so important? Well, the reason for that is that smoking may increase the risk of marginal ulceration and stricture formation, thought to be in part due to decreases in mucosal blood flow. But not only that, smoking preoperatively may actually increase other complications. We know that also postoperative smoking is a bad thing that increases the risk of pneumonia and subsequent surgeries that these patients often may experience, such as body contour surgery or a mastopexy. So smoking pre-op, post-op is just all bad. And as a result, we do recommend that patients stop smoking. Certain centers have different timelines between 6 months and up to a year. In Ontario, it's 6 months. And perhaps we can talk more about that after. Something that we really need to be cognizant about with these patients undergoing bariatric surgery is that they have challenges. And if we don't recognize these challenges in preparation for the patients, they may have a very difficult and challenging time postoperatively. And we need to be sensitive to the fact that many patients have a high incidence of psychiatric illness, and many of that is either unrecognized or not adequately treated. In a good way, many of these patients do a little bit better from a psychiatric point of view in the years postoperatively, but not everyone. And in fact, bariatric surgery can precipitate certain crises that are very problematic to deal with in the postoperative period. So we also know that obesity may be associated with cognitive and reward mechanisms from a neuroscience point of view. And bariatric surgery may actually be instrumental in improving cognition. We know that patients living with obesity may have challenges with memory or executive function, reward issues, and wanting, craving forces that make it so difficult. And bariatric surgery may actually help attenuate these issues. Post-surgery eating disorders are really problematic. In fact, they may be associated with a worse prognosis with respect to weight loss. And we do know that the suicide rate, self-harm behaviors have been noted to be increased post-bariatric surgery. There are many theories of why that is, but nonetheless, that is a observation that is seen. One of the greatest concerns that we have is with respect to addiction, so that lifetime substance use disorder can be high, either preoperatively because patients have chronic pain syndromes from their excessive weights and narcotic use, or alcohol, or other substances, and that we do know that that's something that we do have to look for postoperatively. And some people have addiction shifting between one substance to another. So we need to be cognizant of that as well. In addition, we know that, that about 30% of patients who are smoking before surgery, some of them are able to quit, but a couple of things that are very important. We'd be surprised that the patients that tell us that they stopped smoking, when we check their urine nicotine, actually they're still smoking right on the day of surgery. In addition, a very large proportion of patients that stop smoking do resume smoking. And so that's a big, big issue because of the complications that are associated with smoking. And as I alluded to previously, a proportion of patients may start ingesting and abusing alcohol. And one of the two things that people need to know about bariatric surgery is that for those that have had bariatric surgery, they need less alcohol to become intoxicated in a shorter period of time. So that in and of itself is a problem. And then some patients develop opioid addiction after bariatric surgery, and there are some interventions which I can talk to thereafter about how to deal with that. So we do know that pre-surgical psychological predictors of weight loss, really hasn't been that helpful in predicting post-op success. And it's so challenging that if we were able to predict who was going to do well and who wasn't going to do well, that would be very helpful. We do know that, the eating pathology before surgery and after surgery, does have some effect on the eventual weight loss that is going to occur. Well, these patients are also very unique in their preoperative investigation, and this is one of my most favorite areas to talk about. So they're very hard to evaluate because their exercise capacity is limited. So it's very hard for us to understand what is the meaning of their symptoms. So shortness of breath can be deconditioning, but it can be significant lung or cardiac problems. So how do we investigate them? Well, one thing that's true, you shouldn't shy away from aggressively investigating patients if it's clinically indicated. From a cardiac point of view, there's no excessive risk for doing coronary angiography. Cardiac echo has its role, especially in detecting wall motion abnormality, or in particular, pulmonary hypertension, which may be associated with obesity, hyperventilation syndrome. And then it's difficult to visualize echocardiographic images. And as a result, we need to use contrast with echo to show better endocardial borders so we can assess ejection fraction, or use the MUGA scan as well. In addition, nuclear stress testing is also a modality that can be used to investigate patients complaining of chest pain. Equally important is the pulmonary evaluation, and it's extremely challenging. I mean, many of these patients, secondary to just their elevated BMI, have forces that affect their excursion in their lungs. They have restrictive lung disease. So pulmonary function tests may be very helpful in evaluating patients, and recognizing hypoxia is very important in checking O2 saturations, both at rest and exercise. May be a critical thing for you to recognize preoperatively. In addition, we have screening tools that we can use to identify the presence or absence or the probability of having obstructive sleep apnea. Many of these we use often in other surgeries, as well as bariatric surgery. Sleep apnea is something that I also truly adore, and I can speak for hours on, but I won't. But I think that's very important, that we need to recognize that our bariatric surgical patients are at high risk for obstructive sleep apnea. And it's a shame that many of those patients come to our centers and never being evaluated for that. The gold standard for patients for obstructive sleep apnea is a level 1 in-lab diagnostic polysomnogram. And I think it's very important to use clinical suspicion, because studies have been undertaken that have shown that the utility of screening questionnaire can be very ineffective and miss a high proportion of patients with moderate to severe obstructive sleep apnea. We give patients CPAP that need it preoperatively, and they use it postoperatively, and there's no excessive risk for patients experiencing complication from CPAP, even in the recovery room. What about the role of endoscopy? Well, we do know that many of the patients that undergo screening endoscopy have normal or non-clinically significant findings. There are some indications for endoscopy, especially in patients with sleeve gastrectomy that are complaining of symptoms preoperatively. That's very important to have a good idea of what the anatomy looks like. And especially postoperatively with sleeve, they can have a lot of reflux and symptoms, and you want to be able to rule out, esophagitis or Barrett's esophagus or significant peptic ulcer disease. So endoscopy postoperatively is not an issue. It should be used preoperatively as clinically indicated. We do screen patients for H. pylori and we treat them. Those can be diagnosed by serology or by biopsy on endoscopy, and then we confirm eradication with the urea breath test. And we can't forget the patients that are actually have indication for routine screening, individuals over 50 years old or at higher risk. So we shouldn't forget that this is an opportunity to contribute to the overall health of patients from screening colonoscopy if indicated. What about the risk of thromboembolic phenomena? Well, we're very aggressive in our prophylaxis for individuals with undergoing bariatric surgery. And so we really don't see a high incidence of DVT and PE postoperatively. Nonetheless, when someone does have a PE, their morbidity and mortality is quite high. One thing that is established that we do not use IVC filters anymore. The efficacy is not superior, and the complication risk is significantly higher just from the contraption itself. What about the use of abdominal ultrasound? Well, abdominal ultrasound does have a role when it's indicated, and that would be in detecting patients that may have symptoms compatible with biliary disease, elevated liver enzymes, or fatty liver. And we do know that end-stage fatty liver disease is one of the most common indications for liver transplantation. So it does mingle with our population. In addition, we need to be aware about bone density, and for some patients, a baseline bone density may be important, but most important is surveying for osteopenia and osteoporosis 2 years after bariatric surgery and thereon. Also, great attention should be given to the pharmacologic agents that the patients are taking prior to surgery, because many changes are necessary based on absorption, on compatibility, etc. And they need to be addressed preoperatively and, of course, postoperatively. With respect to hormone, we really do recommend that we stop the birth control pill 1 month prior to surgery. And if one is going to use it for non-contraceptive reasons, they would restart it after 4 weeks. Diabetes requires great attention. That these patients are obviously getting bariatric surgery who are diabetics, and part of the goal is either to improve or resolve diabetes. So in the preparation for bariatric surgery, it's very important to evaluate the patient's blood sugars and take heed of the fact that when you go on a low-calorie diet, you may have to address their medications. For example, SGLT2 inhibitors may be are contraindicated in low carbohydrate diets, and you can precipitate acidosis. So those patients need to be have their those medications held. As well, adjustments to their insulin and other oral hypoglycemic agents may need to be undertaken. So now we have patients that want to have bariatric surgery, and there are surgical options that need to be considered. So in Canada, we have several surgical procedures. We'll talk about gastric banding, but only shortly, a sleeve gastrectomy, a gastric bypass, duodenal switch, and others. And we'll talk about each one of them as well. But we do know the indications for bariatric surgery are patients with BMI over 40 or BMI greater than 35 with comorbidities that are associated to increased adiposity, leading to dysfunction. We know that bariatric surgery is very helpful in decreasing the long-term mortality, and that it induces significantly better long-term weight loss compared to medical therapy, and it can play a significant role in improving or resolving diabetes. But in the long term, we also have to be cognizant that the diabetes can recur, and we have to be aware of that. It also overall improves quality of life in many dimensions, and it also addresses other comorbidities, including hypertension, liver disease, and of course, bariatric surgery with weight loss can improve sleep apnea as well. So there are other indications that we need to consider, and these are indications that involve patients with class 1 obesity that have very poor control of their diabetes, or other individuals that have really given a concerted effort with medical and behavioral management interventions, but have been unable to experience significant weight loss. So when we talk about the choice of the bariatric procedure, a lot of that really does boil down to two things. Number one, are there indications or contraindications for one surgery over the other? And patient preference. And as we involve more and more our patients as a collaborative effort in decision-making, patients do have their own preferences, and we need to respect that as well. And with respect to the gastric band, we really don't advocate the gastric banding, that they are fraught with unacceptable complications. And many of our surgeons in our center spend more time taking out bands and do not put them in. There are other surgeries like single anastomosis gastric bypass, which is are options, but not routinely offered as well. Well, what are the bariatric surgical procedures that I just alluded to? And let's talk a little bit about them. Well, I did talk about the adjustable gastric banding, where it's a band that's put on the top part of the stomach, and from restrictive forces may help lower the ability for a patient to eat. But interestingly enough, there are actually nutritional deficiencies that can result from the gastric band as well. But the complication rate is very high, the success rate is very low, and patient satisfaction is also very low. What about the sleeve gastrectomy in the United States? That's the most commonly performed surgical procedure, where a significant portion of the stomach is restricted, but the continuity of the GI tract is maintained. It's a very effective surgical procedure. And in many ways, it can be a stepping stone to other weight loss and metabolic surgeries, which can include a transition and revision back to a Roux-en-Y gastric bypass or to a duodenal switch. The Roux-en-Y gastric bypass in many centers is the gold standard, and that's where the majority of the stomach is taken out, and the portions of the intestine are attached to the stomach and rerouted later on lower down in the small bowel, and it gets its name by the fact that it shows a figure of the letter Y. This is a very successful surgery, but it is associated with metabolic and consequences. But it is those metabolic and hormonal advantages that occur from this surgery that are responsible for some of the weight loss that we see. There are more aggressive surgeries, the duodenal switch, which is a combination in a way of a sleeve gastrectomy, and then rerouting a part of the intestine lower down, closer to the colon, and as a result, results in more aggressive weight loss, more effective remission of diabetes, but has more complications and more complexities with respect to nutritional deficiencies post-operatively. So just to talk quickly in general between the three bariatric surgical procedures, weight loss, more or less, I would quote a patient 50 to 60% excessive weight loss with the sleeve, about 60 to 70% with Roux-en-Y, and greater than 70% with duodenal switch. They're very effective in resolving the complications. Their risk is fairly low, and each individual surgery has their own, side effects and complications. The sleeve can result in a lot of reflux, and that can be quite bothersome. The Roux-en-Y, it can be associated with low sugars or dumping and late dumping as well. And the duodenal switch, significant nutritional issues as well. So for the most part, however, bariatric surgery does have a positive effect on the quality of life, more physically than mentally, but it is superior to other interventions. And there really is improvement in overall health-related modalities and conditions. And some bariatric surgical procedures are more effective in improving quality of life than others. And much of that also relates to their efficacy, but also the complications or the sort of precautions that people have to sort of follow to be successful. We know that bariatric surgery improves the lipid metabolism, and so cholesterol and triglycerides improve. From a structural point of view, the pelvic floor disorders, urinary incontinence, it also does improve, as well as fecal incontinence. We've already talked about the advantage, and in fact, there's significant improvement in some people, reversal of their fat impregnation of the liver after bariatric surgery. With respect to kidney, we really don't have a sufficient amount of information that we can comment on improvement of kidney function. We know that mortality is affected by bariatric surgery overall. We also know that there's decrease in total and, as I mentioned, and fatal cardiovascular events, and an overall reduction in all-cause mortality, and even with respect to that related to malignancy. So let's close in the next little bit regarding the post-operative management. So with respect to the post-operative care, what I really want to emphasize is a shared care approach, that we have to work collaboratively with many people, with the patient as well as with the primary care physician in the management of chronic disease of these patients, because this is what it is. It's a chronic relapsing disease. And so much attention is required post-operatively to laboratory evaluation. That's on the basis of nutritional aspects, on metabolic aspects as well, and a collaborative work with a multidisciplinary team that involves dietitians, nurses, social workers, surgeons, bariatricians, psychologists, etc. And that we do know that the success post-operatively is very much linked with how the patients follow their regimen post-operatively.
Just doing a webinar period, I should be done in about half an hour period. then I will be cooking dinner, period. If you want, we can reconnect.
So moving on, in addition, we suggest that bariatric centers of excellence have comprehensive sort of plans that they can share and provide the primary care physician, so that the transition from a bariatric center of excellence to the primary care physician is smooth and educational, because that's one of the biggest concerns that primary care physicians have is, what do I do? What do I test? How do I know how to treat? When do I have to refer back to the center of excellence? And so patients do require intensive review in the first year, and then yearly thereafter. And it's very important to understand that the primary care physician is not alone in the care of patients, that they have to have access back to a bariatric surgical center to address complications. Those complications are either nutritional issues, GI complaints, weight regain, which is becoming much more of a significant issue, as well as other complications related to surgery. But what about the message that we want to tell people living with obesity? Well, we want to emphasize, as deliverers of their care, that nutritional supplements are lifelong, that it's very important for the patients to follow a post-bariatric surgical nutritional plan and exercise, because that predicts and helps with a more successful outcome long term. They need to attend all their scheduled appointments, and they can't avoid their post-operative appointments, even in the event that they've gained weight, because many patients shy away from that. And it's a shame, because those are the ones that really need our help. And that we need to be aware and warn people that after bariatric surgery, it can have an effect on moods, relationships, body image. Even excessive skin can be so problematic and distressing to patients. And the addiction of addictions, inability to cope with stress, because at one point they had food that they could turn to deal with stress. Now they don't have that, and it can precipitate crises, as I alluded to earlier. In addition, it's very important to educate your patients, let them know that they may experience their lowest weight between 12 and 18 months, but weight regain is a real phenomena, and that we need to advise them of that and deal with it. Pregnancy in and of itself is also very important, that we do advise patients not to conceive for roughly 18 months post-bariatric surgery. We do know that outcomes, nonetheless, in patients that conceive in the first year are actually okay, but we want to try to avoid sort of a pregnancy situation when they're trying to lose weight and they're now pregnant. And also there are adjustments to their supplements that need to be done with individuals that become pregnant that have had bariatric surgery. There are a whole host of nutritional and vitamin deficiencies that we watch post-bariatric surgery. Due to the time constraints, because I'm almost finished, I'm not going to go through them, but that in and of itself is a talk that is quite interesting. But we do supplement patients calcium and vitamin D, but surprisingly enough, there's a higher incidence that you would expect of vitamin A deficiency and C. We all know that patients could present with thiamine deficiency, and there are neurologic sequelae and symptoms of that have to be addressed. And also with duodenal switch, they can become vitamin K deficient. And then other causes that need to be considered, especially in patients that have diarrhea, zinc, and selenium. But most importantly, I just want to emphasize iron deficiency is becoming a very, very significant challenge for us now, especially in women that are menstruating, and we need to get on top of that prior to surgery, because it's very hard to deal with post-operatively. There are other sequelae. Hair loss is a big complaint that individuals talk about. Usually it occurs between 6 and 12 months, and it does come back in most people, but not all. I won't go through the other nutritional deficiencies. I'll refer you to the guidelines, because the work and the charts are very, very helpful. I will mention, though, that osteoporosis, osteopenia is a real big thing to survey postoperatively with bone density scans. So something to keep in mind. In addition, I alluded to this earlier, but postoperatively, there are significant medication changes that occur that you have to adjust. And I'll just allude to one or two, the psychiatric medications that may need to be adjusted for absorption, but be super vigilant of the fact that if patients are coming back, evaluate them, because the same dose of medication may not result in the same clinical effect that they had preoperatively and postoperatively, and they may be suffering. I won't go into the other nuances of medication changes postoperatively, but it's quite interesting and very relevant. So to summarize, I just hope that this was not too quick, but highlighted the intricacies of the preparation of patients for bariatric surgery, the considerations that have to be undertaken in preparing patients successfully for a positive outcome, and the things that we need to consider postoperatively. Thank you very much.
Okay, thank you, Stephen, for that presentation. And that was a lot of information here. So to the participants, please type your questions into the Q&A box, and we'll try to get to all of those questions as soon as we can. So I just have a couple of questions before we get to the panel. The first one was, how as a family doctor, somebody working in primary care, would you start a conversation about bariatric surgery? At what point would you actually start that conversation?
And so that's an excellent question. So that discussion actually is probably best served in two ways. Number one, it has to be appropriate. So I think that the discussion of bariatric surgery is not something that should be left to a last resort. I think it's something that should be brought up, as you're addressing and asking the permission with a patient. Can we have this discussion? And if a patient is open to that, I think it's very helpful to set out the pillar approach to treating people living with obesity. And that is the behavioral modification, it's medications, it's surgery. And what I typically say is that I'm going to tell you about a lot of things. You don't need to do any one of them, but I want to put it on your plate to let you know about what the options are. So I think that if the patient is accepting of that discussion, I tend to talk about it earlier than later, because you don't want to foster an environment where bariatric surgery is for failures. That's not appropriate. And so I think that just like a diabetic, we like to sort of put the horizon with people living with diabetes, that there are certain interventions that may or may not be options in the future. So that's how I approach it.
Okay. Now, part of having that conversation, of course, has to do with the fact that there's a lot of stigma, not only attached to obesity itself, but actually seeking evidence-based treatment. So we know that there's a lot of stigma, or even misinformation around patients, seeking medication for obesity, or patients seeking surgery for obesity. So what do you think is the underlying reason why these treatments are so stigmatized? And often people say, what, you're not doing the work, you're just taking the easy way out. What do you think is the underlying problem there, and how do you address that?
Okay, so it hurts me to hear that question because it's true. So I think that at the heart of all of this is one or two things. You said the word stigma and bias, and I think that there is both a pervasive feeling regarding how patients have resulted in living with obesity. And I think that that comes from a fundamental lack of understanding of what adiposity and the consequences is all about. So now that I think that we have moved to a better understanding of appetite control and wanting, needing, and the mechanisms that are involved, and taking away the patient as the blame or cause of this consequence, I think that will be one step. The guidelines have made actually weight bias and weight stigma, one of the most prominent and most significant contribution to helping people living with obesity. So when we talk about medications, for example, I say to my patients, well, wait a second. If you had hypertension, we, of course, we're going to do many different interventions, but will we not treat a chronic disease with an antihypertensive medication? Of course we would. And so I also am very clear on calling medications, in my opinion, what they are. It's a tool. It's a tool. No different than if someone is going to run a marathon, they don't run a marathon in their bare feet, they have running shoes. And so medications are just an additional tool to help facilitate the forces that are not the cause or the responsibility of a patient living with obesity. Similarly, bariatric surgery. For patients that have tried other modalities and they haven't been successful, it's just another tool. And I try to emphasize, that these are tools that are successful, that are safe, but I try to eliminate the patient as a cause or a failure.
So Stephen, let's talk, briefly about, the question on how surgery actually works, because, you remember in the not too long ago when we talked about different type of bariatric procedures, we talked about restrictive procedures, we talked about malabsorptive procedures, and as it turns out that the real reason bariatric surgery works probably has nothing to do with restriction and probably has even less to do with malabsorption. So how is our understanding of why these procedures actually work changed over the last several years?
Yeah, well, I think that it's actually, I think it's a combination of a lot of things. And I think that, from a pathophysiology point of view, I mean, there are alterations in neurotransmitters, there are alterations with insulin, there are, as you said, although not necessarily contributory, patients do have a decreased caloric intake, and there is also hopefully an attention to the ingestion of healthier food choices through medical and nutritional therapy, increased activity, hopefully more with increased weight loss. There's greater ability to exercise, and so I think it's a combination of a lot of things, and in some people it's more than others.
Okay, all right. Well, let's take a question from the audience, and here we have a question on the issue around bone density measurements. So the question here is, how often or when would you do a bone density measurement in a patient pre-surgery and then post-surgery?
Right. So I think that it is important in most patients, unless they're very very young, and especially women that are around the menopause, to have a baseline bone density. And not only that, even in men, that's something that we need to be aware of. But we do recommend 2 years post bariatric surgery that we do have a bone density evaluation, because many of the patients can experience deep bone, calcium demineralization in their bones and may be at increased risk, and we do need to intervene with those patients.
So when you talked about how you prepare patients for surgery, you talked about the pre-surgical weight loss and the fact that many centers now use these formula diets to get weight off prior to surgery. But you also talked about the fact that most centers will actually require their clients to stop smoking. And you mentioned some of the problems there. Can we just elaborate on that? I mean, if you have a patient who is a smoker referred to the program, what do you tell the patient? What assistance can you give the patient so that they can actually stop smoking, and why is that really important?
Yeah, so that's an excellent a question. So about 40% of patients going for bariatric surgery are smokers. And we know that smoking within the first year is associated, it's an independent risk factor for 30-day mortality and the postoperative complications that I talked about, not to forget wound and pulmonary and thromboembolic consequences, as well as we talked about strictures. So this is very challenging because, as I said, we know that these patients actually say they quit, don't really quit. And, by 7 years after surgery, almost all of them have actually resumed their smoking. It's interesting to note that this is a much more significant problem with Roux-en-Y gastric bypass, although it's not inconsequential with the complications from smoking from sleeve, it's less so. So to answer your question, so I think that we have fallen short in helping our patients within the bariatric program for smoking cessation. So one of the moves now is to really aggressively try to engage your patient in programs, smoking cessation programs, using other aids, either patches or other medications to help them stop smoking. But most importantly, after surgery, to be able to reevaluate your patients and ask them, have you restarted smoking? And it's interesting that some studies have actually shown that patients, true or not, actually are unaware of the risk of smoking. And I think it's actually quite true that we all tell people to smoke, but do we really sit down and explain to the patients in enough detail? So education, smoking cessation, support groups, sometimes medications are needed to address smoking preoperatively and postoperatively. And then two other issues. So what if someone can't stop smoking? What do we do with that? And then that becomes very challenging because ethically, can you deny someone bariatric surgery who really can't stop smoking? And there are some people that fall on both sides, and I'm not going to comment from that point of view, but perhaps maybe a less ulcerogenic procedure may be preferable, like a sleeve as opposed to Roux-en-Y. So those are the challenges that we're really angsting about right now.
So while we're on the topic of smoking, how do you deal with vaping, and how do you deal with marijuana use?
Right. So we didn't have this problem a couple of years ago, and now we do. So this is our policy or our position. Recreational cannabis use is dissuaded and is encouraged not to occur. So we do tell people to stop smoking recreational. However, medicinal cannabis is accepted and permitted through patients undergoing bariatric surgery, both preoperatively and postoperatively. And, we're not naive. I mean, people are going to smoke if they want to smoke. But medicinal cannabis, for the most part, really is an oral therapy, not vaping. And to comment about vaping in general, so vaping of nicotine is also, contraindicated for bariatric surgery. It's the same effect. So we try to dissuade recreational use of cannabis, especially THC, and medicinal is allowed, and there are no real complications for absorption postoperatively. And there are some papers that use oral cannabis for pain management post bariatric surgery, and I've done that with many of my patients as well.
Okay, so now we have a question from Lynette, who's joining us here from Newfoundland, I believe. And she's asking about whether or not there should be an age limit for bariatric surgery, because the problem they have in Newfoundland, but I'm sure not just in Newfoundland, where we have extended waiting times, some patients actually age out of bariatric surgery while they're waiting for surgery. So do you guys have a weight limit, or is there good evidence showing that beyond a certain age, the risk is too high or the benefits are not great enough?
So, so we do not have exclusion criteria by age, and that every patient is evaluated on their merits. And we have operated on 70-year-olds, but few and far between. When a patient comes to me, and unfortunately, those type of patients fall in my office. What I typically do is I evaluate the patient, and I do look for either increased risks or contraindications that may be associated with this patient's medical status, which may swing the pendulum out of favor for bariatric surgery. But at the end of the day, if a patient is medically stable and feels that they wish to undergo bariatric surgery, we cannot, at least in Ontario, stop someone from going through bariatric surgery. But we do give patients alternatives, and in reality, their actuarial existence, may not be in favor of a net, years added if they are significantly advanced in age. One thing that is true is that there are papers that do show that bariatric surgery in the the 60-plus-year-old population is safe and doable.
Okay, great. So we have another question. Oh, well, actually, before we get to that, while we're on the topic of waiting times, we know that there's a lot of bariatric tourism where people are going off to Mexico and other places to get their surgery and then come back. So, what would you do as a family doctor if a patient told you that they were going to Mexico to have surgery, or came back from Mexico and said they've just had surgery? How do you think those situations need to be handled?
So there are two separate questions. So let's talk about the patient that's having that discussion with the doctor. I would strongly dissuade someone from doing that. And the reason being is that the multidisciplinary care that a patient requires preoperatively and most importantly, postoperatively is not going to be sufficient. One of the problems with what we call orphan patients is that their aftercare is lacking, and they end up with complications that we deal with. So I would wholeheartedly try to dissuade someone from doing that if I were the primary care physician. Not to mention that primary care physician is not going to be supported by any center of excellence for the most part. However, that being said, you can always turn to your local bariatric center of excellence, and we will take care of these patients. Now, if they come back, once again, if I were the primary care physician, I would reach out to my bariatric center and ask for them to be evaluated. However, there are other resources. The Ontario Bariatric Network has a manual for primary care physicians that we are actually actively updating, but it does talk about all the things that are front and center that need to be done for a primary care physician, including what bloods to monitor, how to supplement, what are the alarm bells that need to go off, and to refer a patient back to Emerge or a center. So there are resources available for the primary care physician.
Okay, so Steve, so because of time, we're running out of time here, unfortunately, but there's one last question that I think we can take, and this one is from Colleen. And the question here is about, you've talked about how it's recommended that we screen patients prior to bariatric surgery for malnutrition. And the question here really is, if you find malnutrition in a patient seeking surgery and you correct the malnutrition, can those patients expect to see weight loss?
Yes. So the issue is that independent of that, if you find nutritional deficiencies, they have to be corrected. Then a patient goes into their surgery and will experience the same advantages as for the most part,
Yeah.
as other patients.
So if I get the question correctly, the question is really, would these patients experience weight loss simply by correcting the malnutrition, even if they then didn't go on to have surgery?
Oh, I like that question also. So probably it's individualized to the patient. So it really depends on what is going on with that individual patient. What's their journey? What's their story? So if in fact a patient has malnutrition and has issues with eating or other behaviors that are maladaptive, and they correct them, it is possible that they can turn around their metabolic situation and be successful without surgery. Each patient would have to be evaluated on their own merit. They'd have to be, tested and see what's the mechanism and what are the forces at bay. And if they can be corrected and the patient can make those changes without surgery, then more power to them. That's great.
Well, thanks, Stephen. This was a very comprehensive lecture. I'm sure we could have talked about this for hours, and there's more questions that we didn't get to in the chat. But the recordings will be made available to folks who registered. Actually, I think this one, the recordings are not going to be made available, but I'm sure that this topic is going to come up again. So to everybody who's here live, thank you so much for taking the time to join us. I hope you found this as enjoyable as I did. We'd absolutely appreciate your feedback. If you haven't already done so, please use your camera or cell phone to scan the QR code, because that's going to take you to a link where there's a few questions that we'd like you to answer. Once again, thanks everybody for taking the time, and thanks to you, Steve.
Okay, thank you. Be safe.